Okay, good evening, everyone. Thank you so much for making time to be here today, and welcome to the webinar on Understanding Dementia by Remy Okay. Now, my name is Mary Lanion. I am an Agile practitioner. I work as an Agile enterprise coach. I work internationally. I am a trainer and mentor. I actually mentor upcoming Agile practitioners, and I am the convener of the Ninja Professional Group. Now, what is this group all about? It is a value-driven ecosystem. It is a melting pot of Nigerian professionals. It is an opportunity for us to showcase ourselves as professionals, both individually and collectively, an opportunity to leverage our knowledge and experiences. Again, an opportunity to mentor upcoming professionals, create opportunities for collaboration, just like we're doing right now. And it is also an opportunity to actually share our expertise, as a corporate social responsibility. And if you're a Nigerian and you are a professional, by all means, please join us. We are on Facebook and on LinkedIn. Now, Remy Okay is a Ninja professional as well. Thank you so much for volunteering your time, because this is what we do on the platform as professionals. We volunteer our time to give of our expertise. Thank you so much for making the time to share of your expertise and create awareness about dementia, which is such, a taboo in Nigeria. It's not something we really like to talk about. And we really do appreciate you for making that time. So let me introduce Remy properly. She's a professional. She's a dementia professional with over 20 years experience, an MSc in dementia studies, advanced diploma in dementia studies from University of Middlesex. And she has worked with a leading dementia voluntary organization in the UK. And she has also worked in clinical teams within the NHS. So as you can see, she really does know her onions, and we really can't wait to get informed by her. So a quick check-in. Where are you all calling from today? If you can just put that in the chat box. How are you doing today? We are still battling COVID-19, but of course, the lockdown is easing slowly. So in the chat box, please, how are you doing? Where are you calling from? What's the weather like at your end? If you can just put that in the chat box, that would be nice. Lots of rain in Lagos. Oh my God, Kemi, I'm sorry to hear that. So that means you are homebound. From Lagos also, Dr. Fatmo from Lagos, nice to have you here. Abi Akerele from where are you? From London. Oh, we are both in London. Okay, cool. Okay, I think there's somebody else with you in Lagos. It's raining there. Okay. Oh my God. Shola Bomi says, I'm in Lagos and my streets are flooded. I'm so sorry to hear that. That's so typical of Lekki, isn't it? Little rain and everywhere gets flooded. Anyone else? Okay, somebody's in North London and the weather is cool. I'm happy to hear that. Nice to have you all here. Nice to have you. You're welcome. Thank you so much. And please join us on Ninja Professional. Okay. So a little housekeeping. This is a recorded session, so it's being recorded right now, so the people who have missed it can catch up with that. Everyone will stay muted so that the quality of the recording can be quite good. And there will be a Q&A session. By all means, please participate. And there will be some polling. Again, please kindly participate. And where possible, if you really feel you need to engage with us, to talk to us, we will unmute you. And at the end, we will do a small selfie, if that's all right with you. Okay? So please note that this webinar has been designed to answer general questions with respect to the topics covered on dementia. It would be impossible to address individual or specific case, as a full assessment is usually required. If you do require more information, please do not hesitate to contact Remy Okay. And her email address will again be shared at the end of the session. We will share her email address again. So over to you, Remy. Please take it away.
Thank you. Thank you, Mary, so much. Next slide, please, Mary. What is dementia?
Can you just say,
Can
say
we
something
just,
first before we do the poll? Can
yes,
you?
put anything you understand about what dementia is in the chat box, whatever comes to your mind, if it's something you've read in books or watched in movies or in newspapers, whatever you understand, even from personal experience, please feel free to share with us on what is dementia. Okay, no. We can see some messages coming in. Old age madness, old age mental illness, memory confusion, that's part of dementia. It's not a disease of an old age. People under 65 can also develop dementia. So I welcome everyone to this webinar so that we can all be informed. We can all have the right knowledge about dementia, a better understanding. And in the absence of a cure, we hope that people that have dementia, that live with dementia, will continue to be well supported within our local communities, within our homes, within our families, as human beings and not less than human beings. Thank you very much. Next slide, Mary, thank you. So dementia is a brain disease. By brain disease, I'm not talking about just one disease. It's a disease caused by damage to the brain. So we have a different kind of diseases that takes place in human bodies, in the brain, that can cause dementia. And when there's a disease of the brain, we see all the changes that people go through. And that's why we see the changes in them, and we really try and understand what's causing this. We feel it's something else, but there is actually some changes going on in the brain.
Can we all stay muted, please? Remy, you are muted. Remy, can you unmute yourself? I think I muted you in error. I was trying to mute somebody else. Remy, can you unmute yourself?
Yep.
Okay,
right?
yeah, that's
okay,
fine.
sorry.
Can everybody else
Can
please
I...
stay muted? Otherwise, it interrupts the quality of the recording. Can we please stay muted? Aderemi Fatoke, please stay muted. Thank you. Remy, please continue.
Okay, so it is a brain disease. It's not one disease, but diseases that cause damage to the brain. We all know that the brain covers everything we do, from our waking moments to the sleeping moments. So the brain is the engine box for our lives, for the body. So when that brain has a disease of one kind or another, could be Alzheimer's, could be vascular strokes related disease, then you find the changes that we call dementia. So dementia is an umbrella term for all those symptoms that people experience when they have a damage to the brain. It is also a form of disability, in the sense that when the brain is compromised because the brain cells are not functioning properly, or because of the diseases that I've expressed advance into the brain system, some brain cells starts to die off, some don't work properly, some don't send messages as we want them to work, and all these challenges also causes the people who live with dementia to experience some form of disability. Not necessarily physical disability, but with progression, then you have other forms of disability starts to manifest. So it is a form of unseen disability because we cannot see these changes going on in the brain. We tend to forget that this person has a problem, has a disease, and this is why the changes that we now see. Dementia is also a progressive disease. By progressive, it means it will get worse. It is a disease that will deteriorate. It's a disease that will not get better. It's a disease that, with all the care, with the medication that we have currently for dementia, it will continue to progress to become a severe form of dementia. And I also have to remind people that as a disease is a disease that affects people. The person has dementia. The person is a person. The person is a woman. The person is a man. The person can be a gay person, can be a lesbian woman. It can be a transgender. It can be from all walks of life, rich or poor. It hasn't got anything to do with dementia. Thank you very much. Mary, the next slide, please, because we do have quite some information to cover. We thought to look at what people feel that dementia isn't. What dementia isn't is a spiritual attack. Sometimes people feel that this person cannot be the person that I know. This person is being attacked by some spiritual forces that they cannot control themselves. So the way we'll then treat these people will be different. We'll be looking at the spiritual element, not to see that there's a change going on in the brain and this person is not being deliberately mean or is not being a child. They are having a disease of the brain, and that's what you see. It hasn't got anything to do with any spiritual attack. And the treatment of those people who believe that there's a spiritual attack could mean them taking the person with dementia to churches for prayers, thinking that they will get better, taking them to religious priests, taking them to traditional healers, giving them herbal remedies, thinking that that will improve their problems with memory and behaviors, because they don't understand that it's something that is progressive and it's in the brain, and the disappointment of seeing the changes continuously manifesting in the people's life means that the people living with dementia will not receive the right treatment, the support, and will not feel safe even in their own homes. Another information that people normally think that dementia is not is a senile dementia or madness. People think senility has to do with old age. When people grow old, they act funny, they're senile, they're, oh, forget it, that, there's madness going on in the family. Dementia isn't senility, and neither is it madness. It is a disease that is attacking the brain of all the other diseases that can go into the brain cells and nerve cells in the brain and cause memories to be compromised, and also ensure that people who would otherwise be well start behaving in other ways that we do not understand, and we think they are becoming mad. So dementia is not madness, and it's got nothing to do with senility or someone growing old. People who are not old, who are under 65, do go on to have dementia. Judgment of nemesis or karma. Some communities believe that when people grow old and they have difficulties in their lives and they are not well, that is judgment time. They've done something wrong in the past. They've done some wicked things in the past. Now they are paying for it. Karma, something in existence in the past, something bad, something wicked. Now the laws of karma have taken over to punish them in their old age. So when you think about that, how do we then support this person with dementia when we think that they deserve to be unwell? They deserve what their behavior deserves to be treated badly because they're already a bad person? Then they will not have a positive experience while they are ill, and other family members will also treat that person very unfairly. Some people think that dementia is growing old and then becoming like a child. Dementia is not growing old and reverting into childhood. An adult older person cannot become a child again. But because there's a brain damage, there's diseases going on in the brain that is causing the brain cells not to send messages in the right manner. And for this person that has dementia to behave in other ways that challenge us, the family carers, then do we start treating them as children? Do we start taking over their lives and making decisions for them and treating them as if they have no say in their levels of care and how we care for them because they're now children? We take charge. Dementia is not transmissible. You cannot catch it from someone who has dementia. So we don't need to run away from them. We don't need to stop talking to them. We don't need to ignore them. We can't catch it. It's not an STD, which is a sexually transmitted disease. Oh, that's why they have dementia. Oh, they've been so sexually active in their young age, and that's what caused the memory problem. They've done so many, bad things, when they were young. So now, no wonder they have this memory problem. It's not STD at all. And dementia is also not functional mental health. Mental health, as we know, there are different types of mental health conditions, from depression to um, schizophrenia to bipolar, to other obsessive compulsive disorders and personality disorders. The reason being that with mental health disorders, people can recover with the right support, with the right medication. They can recover and they can live full active lives. They can be back at work. They can be good parents to their children, and they can learn to know what their triggers are and be supported to live well. Whereas with dementia, I'm sorry, it's progressive. There's no cure today, and it will continue to deteriorate. Thank you very much. Mary, next slide, please. So what are the early signs of dementia? What do people normally experience for them to start having concerns? It might be mild, depending on the type of dementia, which is people becoming slightly forgetful. We do know that there's some element of forgetfulness as we grow older, but with memory loss, it's more than forgetfulness. It progresses. So when someone's forgetful, you find that their language communication also becomes compromised. How they understand language and communication. You give me a question, I think about that question, I wait, balance it, and I absorb that question and decide what am I going to give back as an answer that is appropriate to the question you've asked me. That is almost like a 4 different communication strategies going on before that person answers. Definitely with dementia, that starts to be compromised. You've given the question, short-term memory loss, they remember what, they can't remember what went in between the questions, and they can just remember you say name. Name what? What are you asking me? I'm saying, what is your name? What? Name? They can't, you have to be changing and adapting the way you communicate with that person. Eye contact, hands on them, good level of communication. What is your name? I am Remy. What is your name? Oh, Titi. Oh, Mrs. Titus. Because you've engaged more than communication, which are the body language that we take for granted. They now need those cues to be able to communicate better with us. Confusion, disorientation, confusion as to time, confusion as to activity, confusion as, appointments, the diary, everything. They need help in being able to live daily lives. Disorientation, not being aware of certain etiquettes, not being aware of what to do when there is a visitor, or not recognizing the environment, asking constant question, repetitiveness, what's going on, what time is it, what are we doing today? So it is constant. And no matter what answer you've given them, short-term memory loss, they've forgotten. They ask again, they ask again. So it can be quite frustrating for those listening to that, not knowing what's going on. To understand dementia meaning would mean that you know that this person has forgotten what you said. And instead of repeating, said, all right, then this is what we're going to do. You take them for that activity. You take them to have the bath. You take them to take the medication. You move that inquisition along so they can actually physically see what is going on. Then when we talk about activities of daily living skills, what are they? What are activities of daily living skills? We get up in the morning. We know we need to go to the bathroom. We know to brush our teeth. We know to change our clothes or have a shower. We know what we're going to do for that day. Are we going to go to work? Are we going to come downstairs? Are we going to, prepare breakfast? Are we going out? Do we have appointments? Those, how do we dress for the appointment? Is it raining outside? Do we wear our boots? These are our activities of daily living. How do we take care of our personal care? How do we take care of our environments? How do we get from point A to point B? This starts becoming compromised. Motor skills and sequencing. Yeah. Motor skills, our hands, our legs. How do we move? How do we sit in the right seat? How do we coordinate our daily movements all over the day? Do we step properly? Do we see that we've got one more step to take and we fall down because we've not looked properly? Are we sequencing our activities when we are making breakfast, making a cup of tea, cooking our meals, even dressing to go out? I'm rushing somewhere. I know someone's picking me up. I've got my pajamas, but I've worn my clothes on top of my pajamas. These are sequences of lives that we take for granted. Visual and auditory hallucinations. Those are other signs that people experience depending on the type of dementia. So they can see things in three-dimensional, or they might misjudge distances. So they want to sit in a chair, they sit at the edge of the chair, and they can have a fall. They're not meaning to fall, but they did not judge where the chair is for them to sit properly. So people tend to have to support them properly in things like that. And auditory hallucinations, you find people talking out to themselves, answering questions. People worry that they're seeing something, they're responding to the auditory hallucinations. Mood changes, anxiety, paranoia, changes in habits. This is part of a brain damage. Someone's always dressed impeccably, who you can see from when they were even, young, the way they dress, their pictures on their walls, very well coordinated, then you find them not dressing properly in the same outfit for weeks, or they refuse to change their clothes. And the families are saying, Mom, go and have a shower. Yeah, they'll go and have the shower, they'll go back into the same clothes. They don't want to change those clothes. They don't realize they need to change these clothes. So how do the family members support them and their well-being to make sure that they do not make them feel less than a person because they have the dementia, and make them feel valued as adults with a disease? Behavioral changes as well, their routines changes, and things that they enjoy, the things that have always been interesting for them, they look away because the coordination, the cognitive facilities to engage in these activities is diminishing. But you can't see that. Someone that likes to play gads, that likes to play Ludo or dominoes, they sit there and you are encouraging them to play that. What do I play now? And you're like, but Mom, we've always played these cards. Okay, all right. But with gentle support and encouragement, she might probably play that card without you rushing her and giving her time. Apathy. People with dementia also, as dementia progresses, you find that people see this apathy as some form of laziness, but it isn't laziness. It's just that they lack motivation. They lack the gumption that makes us to get up in the morning. Oh, it's a bright sunny day. I'm going to go to the park. I'm going to go for a walk. I'm going to see my friend next door. They can just want to sit down, do nothing. They watch the same program. They don't change the channel. These are things that we then worry, and we start feeling, how do we support this person to have the same quality of life, even with the dementia, so that they are not just vegetating. Friendship starts to change. They stop ringing their friends. They stop taking phone calls because they think it's a nuisance or it's making too much noise. Just stick that phone away. They become more isolated because the friends will come and visit. They don't know what to expect. She's behaving funny. She shouted at me last time, or we went out to a coffee shop. I was embarrassed. So the friends stopped visiting or inviting for coffee. So they do suffer some sort of loneliness. Mobility difficulties, as the brain is challenged. The brain governs all our motor neurons, all our nerves, all our mobility. We find that people start to stutter in their mobility. They start to falter and stumble, having falls, and they need to be really supported with mobility as well. Difficulties in making choices and decisions. Will this manifest? You ask, oh, would you like a cup of tea or would you like coffee? Oh, I want tea. This person doesn't drink tea. They drink coffee. Then you say, would you want coffee or would you like tea? Oh, I want coffee, because they could only hear the same word coffee. And that's the first thing that they remember. So it's about ensuring that the knowledge of this person that you use it to look after them, to make the right decisions for them. You know that this person doesn't like certain spices or they're allergic to certain spices. They might not be able to tell you when they have dementia. Is to make sure that there's continuity of care. Problems with continence. The brain also gives us that feeling that we've got to go. I've got to get ready and I need to use the bathroom. That starts to change. By the time they get up to go, they're having accidents, or, they get to the bathroom, they forget to take off their trousers, or they sit on their dresses. These are problems that people face. And when that happens, family carers get upset. They think it's deliberate, to give them more work, to tidy up, to want a shower. I've got to go out, I've got things to do, and I've got to do all this as well. So it's about knowing that person, that there's changes now. We've had a few accidents last week, and having this sort of routine to support them. Right, now we've got to use the bathroom. Now you've had your meal, 5 minutes, let's go to the bathroom. We're going to bed now, can we use the bathroom first? So a little bit of changes in routine will ensure that accidents are minimized. Thank you, Mary. Next slide, please. Right, this is the brain image, a brain scan, which I took from a journal. And we have the citing for the journal, which we will share with members on the forum. The global cortical A is the global field of the brain looking from the top. You can see that's a normal brain size. You could see that the brain is full in its hemisphere. The line that divides the center of the brain, you could see that it's close together. So when this scan is done, this person has a healthy brain. Then we move to GCA1. You could see some slight changes. Can we type in the chat box, what changes are we seeing in this GCA1 second image of the brain scan? We can see that there's a slight decrease in the volume of the brain. We could see some gaps. We could see that the line between the center of the brain is more slightly wider. Then we now go to the global cortical atrophy 2. It's more distinct. You could see that there's more gaps between both hemispheres of the brain. The brain seems to have shrunk more. You could almost see that they're closing in the volume of the brain. So you could see that the brain cells are being damaged. Some brain cells are dying. They cannot be functioning as they should because the gaps are widening to keep the communication open for the brain cells to be more effective. Then the global cortical atrophy 3, which is what I would say is the advanced form of dementia, when you can see that the brain has actually really shrunk very much so, and there's more gaps, and the line between the both hemisphere of the brain is even much wider. So you could see that anybody having that sort of severe dementia will then have more problems in language, in communication, in mood swings, in ability to coordinate personal care, to understand what you're trying to tell them, to organize their daily living skills, and they will need more help.
Remy, can you please stop for a minute, please? Can everyone see the brain scan? I am sharing the brain scan. Can you please type in the box if you can see the brain scan? Some people say they can't see it. Can you see the brain scan?
Yes, from Kemi.
So
yes.
who is not seeing it? Everybody is seeing it. Someone isn't seeing it. Okay, I thought I wasn't showing anything all this while.
Okay.
Okay, I'm sorry to interrupt you. Please continue.
Okay, so that is what actually takes place in the brain when someone has dementia. And we can see this, but people who are caring for those with dementia cannot see this. And even when they do have the brain scan, depending on when they have the brain scan, it might not really show the kind of changes that the doctor can say categorically, this is the problem. They might suspect a little bit of memory problem until you then repeat the scan in maybe 6 months' time or a year's time. Then the doctor can then say categorically, this is some form of dementia. This is the kind of dementia the person has. Thank you, Mary. Are we happy to move on?
Okay, so I'm going to run a poll now. I'm going to run the poll. Just bear with me. I'm going to launch the poll. The poll says, have you experienced a family member or friend living with dementia? It's a multiple choice. Okay, Remy, I will soon end the poll so you can see what the results look like. So, okay, I'm about to end the poll if that's okay with everybody. Attendees are now viewing questions. Okay, people are still voting. Okay, I'm going to stop the poll now. Okay, I believe we have 25 people in the conference, and I'm just ending the poll and I'm sharing the results. Can you see the result?
Yes, I can, Mary.
Okay, so
It
12
seems,
people say, which is about 60% of the attendees, say they have experienced a family member or friend living with
okay.
dementia.
Okay.
Okay?
Thank you.
Okay.
Thank you, Mary.
Okay. I'm just going to get rid of that. Okay. So I'm just going to.
Right.
Okay,
Thank you
there
for
you
the
go.
poll, Mary. That's brilliant.
Thank
So
you.
how many types of dementia do we feel are there? When I say how many types, can you please put that in the chat box? The number of different types of diseases that you feel can cause dementia, that you know of or you've heard of, or you just feel out of the blue from your mind. Please, let's have something coming. Thank you. I've seen a 5.
Mm-hmm.
Any other more suggestions of how many types we think there is out there that has been actually diagnosed? It's not in the air. It's not from. Okay, can we have some more rough guesses if you feel like you have a idea from what you've heard other people say or read? Any more coming, Mary?
No, just 5 and 3.
Okay, any more?
Let me see.
Okay.
We've got 5, 3, 3, 2. Okay, so over to you,
Nothing
Remy.
higher?
No, the highest we have is 5.
Okay, right. Okay, actually we have over 100 different types of dementia, all diagnosed. The more common dementia, I'll discuss about them, and then we have some more rarer types of dementia. So Alzheimer's disease is the most common form of dementia. This is formed when there are prion deposits in the brain, protein deposits in the brain. We don't know how they get there. We don't know what causes it. But once that starts happening, people start to have significant memory loss. And it's also a gradual process that you can see the changes in behavior and language, but mostly with the memory problem. It's the most common form that has been diagnosed, followed by vascular dementia. Vascular dementia, we know, is when the brain experiences significant um, stroke, or sometimes what we call lesser strokes, small vessel strokes in the brain, which will then cut the supply of oxygen and blood to that part of the brain. And then we can actually see that this person has had a stroke from the physical symptoms that we see, maybe unilateral loss of limb and arm movements, or maybe they have problems with mobility or speech. Then we know that this person has had a stroke. But with vascular dementia, when they are treated for the causes of vascular dementia, which is due to the blood vessels either narrowing in the in the brain that causes them to have the stroke, and or they have a high blood pressure that is now treatable, and with a lot of support with rehabilitation, they then plateau and remain stable. But we do know that stroke is continuous. They might then have another stroke in another few years, and those conditions will deteriorate further. Whereas some would have mini strokes, small vessel strokes right throughout their lives, and you'll see progression of dementia as well. Dementia with Lewy bodies is also another form of dementia, which is caused by deposits of Lewy bodies in the brain cells. When these deposits occur in the brain cells, they stop the brain cells from working and sending messages as it should do. So it becomes, very difficult for the brain cells to send messages to the brain for activities, and people with dementia then will also have problems with hallucination, because Lewy bodies also result in a lot of hallucination and difficulties in mobility. Other forms of dementia, the frontotemporal dementia, which, as the word suggests, is when we have dementia in the frontal part of the brain and the side of the brain. And those are the areas of the brain that governs behavior and the way people would understand social skills and language. So people tend to show changes in behavior much more early than the memory problems. People can also go on to develop what we call mixed dementia, which could be a combination of Alzheimer's disease and vascular dementia from the strokes. So they can see from the brain scan that there are two different kinds of dementia that the person experiences. Other rarer forms of dementia are the post-cortical atrophy, also known as PCA. This is a form of dementia when the brain cells in the back region of the brain and the upper areas of the brain at the back starts to deteriorate due to a disease called posterior cortical atrophy. And the brain cells at that area starts to be compromised, they start to disintegrate, they start to die off. When that happens, that area also governs our vision. So you find that people have, in the early part of that dementia, they cannot recognize people's faces. Maybe they might be able to recognize from the voice, and they have difficulties in reading and understanding. And then you start progressing towards memory problems and other difficulties with dementia. We also know the Parkinson's disease as a form of dementia, where initial difficulties people experience with Parkinsonism is rigidity and mobility difficulties, and mobility and movement difficulties. But then it does progresses to a dementia where they then have memory problems, communication problems, mood problems, and they, because it takes so long for the brain to work, and because Parkinson also affects the way people understand things. In addition to that, we also have some more rarer forms of dementia. The Creutzfeldt-Jakob disease is also a form of dementia. It's a form of dementia that when people have it, they experience, a lot of mobility problems, because it's very similar to a new variant that also discovered, which is due to similar to what we call the old mad cow disease, when you can see that people experience problem with mobility and they have Parkinsonism symptoms, but then they also continue to have problems with memory. HIV progresses into a form of dementia. Huntington disease is also another form of dementia, but this is inherited. And people then develop a lot of mobility problems. Multiple sclerosis is also a form of disease that causes dementia. Korsakoff syndrome might be unfamiliar. That is a different kind of dementia that people experience when they have been alcoholic. It's a alcoholic-related dementia. And after years and abuse of alcoholism, they start having severe memory problems. But if they're able to stop drinking, it halts the progression of that dementia there and then. They will not get better, the memory will not improve, but it certainly will not get worse because they have stopped drinking. And Down syndrome is also a disease that can also progress to some form of dementia. Thank you. We've got another poll, everyone.
You please put it in the chat. Do you think there's a cure for dementia?
Okay, let's see what our audiences say to that.
Is there a cure for dementia? Do you think? Okay, no.
Okay, we've got some no. Not sure, Kemi. Okay. Is the poll coming in?
Yes.
Okay.
I've got mostly no.
Okay.
Okay, so there seems to be some quite
consensus in there.
Consensus there with regards to the cure. Okay, yeah. So if there's no cure, what do we do?
Right. Till today, I must say to everyone, there is no cure. There are 3 licensed drugs for dementia, which I've listed on the slide. Donepezil, which is brand name for Aricept. Rivastigmine, which is the brand name for Exelon. Galantamine, which is the brand name for Reminil. All these medications for dementia are not a cure. All the medication will do is to slow down the progression of the disease. That is if the person taking either of those medications or a combination of them does not have bad effects or side effects that then outweighs the benefit of taking the medication. So we do understand what side effects is for medication. We could just put anything that we remember or we know from experience, side effects of medication. on the chat box, which could be dizziness, a change in taste in our mouth. It could be, mouth dryness. People sometimes feel nauseous with medication and they lose appetite. They're not eating well. Some might even hallucinate with medication. So sometimes family members will decide, is it really worth it? Will this person's quality of life be enhanced by taking this medication to slow down the progression of the disease if they are constantly, losing appetite or constantly feeling sick or constantly feeling dizzy or complaining of pain all over their muscles. So these are decisions family members decide to take. And the acetylcholine is the depletion of the chemicals in the brain that makes it difficult for our nerves and cells in the brain to send messages when we need to carry out functions or understanding. So all those three medications will work in different ways to improve and slow down the progression. From evidences between 6 months to 12 months to slow down the progression. And after that, people sometimes decide to keep people on this medication because even though it's not giving any improvement in memory patterns and behavior, but they feel that it makes this person much calmer and relaxed and easy to work with, easy to care for, more cooperative and less challenging. So people sometimes keep people on this medication for a lot longer. So if we say an average of 10 people taking either of those medications, 3 members of that 10 group will say, wow, absolute, brilliant. Oh, mom's now doing this, dad's now doing that. There are things that this person have not done in months, they're now doing. Maybe making up the bed, maybe having their shower, maybe dressing up properly, maybe even calling friends or, picking up the phone. So they can say from behaviors if this is really helpful. Another 3 might say, I really cannot say that there's been a significant increase or improvement in the behavior, but they seem a lot calmer or less aggressive verbally towards me when I want to do something, or when, they're more relaxed at home. They seem a lot happier. So there are different ways this medication can help. And the remaining 4 might say, nah, it's not made any difference, but we'll continue all the same. Thank you, Mary. Next slide, please.
Just before we move on, somebody said, this is Shola Bomi Gaba.
Yeah.
She said, it sounds really scary though. She said this sounds scary considering that it hasn't got
a
cure.
Okay, it is scary, but at the same time, I tell people it's as long as a piece of string. When you know what the problem is, doesn't that equip you better not to be overly stressed about things you cannot change? Even if you do not have a diagnosis, the changes that you see are something you can put in a diary, and you can say that definitely there is a problem. How can we now solve it? How can we support? 2, yes, there's no cure, but how do you think that person feels? For them, everything's fine. I've always been myself. This is me. I don't want to eat. I don't want that food. I don't want medication. So who is going to make the changes? It is us who understand that there's a problem, even without a diagnosis. You sit with this person, you hold their hands, you talk to them, you smile, you make jokes, and then you say, oh, it's time for the medication. You just don't put the medication in front of them and expect them to swallow it. There is a relationship involved when there's someone living with dementia. You have to work on that relationship to ensure that this person sees you as an ally and not someone who's trying to take over because I can't do it. I've always done it. I've always cooked, and yet we put sugar in tea. We put salt in sugar. We put, the wrong things in the food. We put food that is meant to be cooked on the burner, we put it in the oven. So, but when we know, we are better able to support these people and avoid accidents, them burning themselves, them burning the house down, because we know and we put things in place to support, even if it's gently, without taking over. But not supporting means this person is going to get worse. Their well-being is going to deteriorate. They're going to feel the whole household is against them. It's only them against the world, and they're going to feel more isolation. So the knowledge is the power that we need to care for this person, because something's going to kill us one day or the other. Somebody healthy walks out of my door, got hit by a car and dies. So what is about health if we're not going to make use of what we know to do our best? Someone healthy dies every day. So why should dementia be something that we now lays our hands off? Oh no! And leave this person to struggle in a world that it cannot control, it cannot change. We can go into that world and explain what is going on and support them, make meaning for them, show love, show support. Even if you wear your pajamas and you wear your shirt on top, as long as that person is dressed, they're not naked. Why can't we talk and just get on with the day? If they need to go out, we might suggest, and if they don't want to, who does it bother? It bothers us more than the person living with dementia. Thank you, Mary.
So can dementia be prevented? I mean, what can we do to minimize,
Do people want to put something in the chat box? Can dementia be prevented? What do you come up with what we've talked about so far? Can we prevent it? Okay, some yes has come up. Any more coming up? Can dementia be prevented? Okay. Dementia, only with exception to vascular dementia, can be prevented, because we can't see the changes going on. We don't know when the changes starts happening in the brain. We don't know when the parent starts deposited in the brain. We don't know when the Lewy body starts depositing in the brain. We don't know when the brain cells starts dying off in the brain or are being challenged. We can only know from the behavior and the difficulties the person starts to exhibit. But they provide so with vascular dementia because we know the cause of that. We know the cause of dementia is due to someone having high blood pressure and not either taking care of it or not taking the right medication, having review, or having a bad diet. And so the blood vessels going to the heart is significantly reduced by bad cholesterol. And that's restricted the blood flow into the brain, and they have a stroke. So we know that you're looking at what is healthy for your heart is also good for your brain. You know, a balanced diet, a good session of living well, not smoking, drinking in moderation, not, ensuring that we have an active later life, which means, we are socially active, we read, we engage with other people, we go out, we keep living well, even when we are old. All this helps to, and we take care of other health conditions that people have in later years, like diabetes, like heart condition, like what other health condition that we have, depression. We take care of our medication so that we can live well. Thank you very much. Mary?
Yeah, thank you very much, Remy, for that very, clear, and, easy language, of course, with the exception of the names of the diseases, that was, quite good for me in terms of being informed. The one thing that you seem to have just said is that, depending on our lifestyle, we can minimize or prevent it. So you said something
vascular,
about vascular
dementia.
just the vascular
just
one.
the vascular
I see.
dementia, because
Okay,
we
just the
know the
vascular.
cause of that.
Okay.
Other forms of dementia.
Okay.
Someone typed in that is an active lifestyle able to
I'm
help.
just going to bring up the chat. Let me read out the questions.
Okay.
Can be slow. Somebody says can be slowed down, not prevented. Okay. Is forgetfulness at a young age a sign of things to come?
No, it isn't. Some people are forgetful by their nature, except if that continues to affect other aspects of life and activities of daily living.
Okay.
Yeah, so far from evidence, there's been someone who's 20 who's had dementia, but it's very, very rare.
Okay.
People mostly are under 65 or over 65.
Okay.
And memory loss, especially, it's more than that. Don't forget, it's progressive. So by being progressive, they will continue to see more changes, and then they can then go to have conversations with the doctor. But yeah.
Please unmute yourself if you want to directly ask Remy any questions,
There's a
please.
question that came from Shola Bomigaba about active lifestyle.
Can you read that out, please?
It says, does active lifestyle helps? What being active does is it helps that person to maintain well-being because they have done the same routine that they are used to for so long. It becomes like they don't have to think about it. So being active means they remain active for much longer, even in their dementia, than someone who's always been sedentary, that's not read books, that's not been stimulated by things that other people do, read newspapers, going out, going for walks. So being active in later life also helps.
Okay.
Okay.
Autism and dementia, are they similar? Any similarities?
Autism is a different form of disease, but with dementia is a memory and brain disease. Autism is from birth or acquired, and dementia has to do with people having a brain disease. So
Okay.
autism is a form of learning disability, which is
Okay.
different from Down syndrome, which is also a disability that is more prone to dementia in older years, which
Okay.
has just been a recent evidence as well.
Another question, who qualifies to care for dementia patients?
Everyone. Why not? And they're human being. Everyone qualifies to care for people with dementia in their families, amongst their friends, in their communities. You don't have to have a special qualification to care. You just need to understand that this person is suffering from a brain disease, and the behavior you see, you try and understand it, you try and work with them, you try and not expect that everything you do every time you'll get it right. Whatever you did yesterday might not be right tomorrow. They might just not be in the mood. We go through moods. So people with dementia, despite that, dementia doesn't stop them being who they are. They are just so influenced by how the dementia affects them.
So someone said, does that mean they don't need special care? I guess this is stemming from the fact that you said anyone can care for them. So if anyone can care for them, does that person, for example, a family member?
A family member can care for them.
Yeah, but do they then need to go for special training?
They don't need any special training. They only
Not
need to
even.
know that this person has a problem, and understanding that problem means that they will then use that understanding to support the family. If they want to understand better and understand dementia, yes, they could go for a training for that. But this is someone that you've lived with. This is someone that you know. This is a partner. This is a friend, or this is your own parents as well. You know how to care for them. You know their routines. You know they don't eat certain food. You know they prefer certain food. You know, those are the elements of a care plan, is looking at what works for that person as a person. I wouldn't know, except if I ask the questions from the person that has the dementia. What would you like to eat? What are your things that you'd like to do? And then ask the carer, oh, he says he used, oh, no, 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 no. He's not done that since 20, 30 years ago. Oh, no, 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 no. You could see the varieties of what the person with dementia now feels that they are doing or they can do. Oh, they've always hoovered, they've always tidied up. I'm still cooking. And the carer is like, I'm doing all the cooking. She's not cooked in 2 years. She doesn't even go inside the kitchen, you know? So caring is caring whatever form or manner it takes. We just have to know that if we then need to understand more, we can then look at doing a training to understand more, so that when other things we are not sure of, we are confident in what choices we make for that person in their best interest when they are not able to give us an answer.
Okay, someone is typing here, and would you start to advocate special training, especially taking into cognizance that care might be in the hands of persons who is not familiar with them? I guess in that case, yeah.
Yeah, in that case, yes.
Okay.
It helps.
And even if it's a family member, I would imagine that I still need to really understand dementia to a deeper depth, if you like.
Exactly.
To be able to care for them. So I guess that's what people mean by, training, really.
Training.
Okay.
And then our dementia sufferers patients, there's still this word in suffering that goes around everywhere, where people feel that people with dementia are suffering. They don't see themselves suffering. they have a memory problem, they have a disease of the brain, but they're not suffering as we will see it. And when we see them as suffering, it tends to impact on how we treat them because we feel that they are suffering, so we've got to do things for them rather than engage with them as participants in their care. Because we know this person, this is his lifestyle, this is their routine, this is what she likes to do. So we can still continue to live well with dementia because of the knowledge and the history we have of that person, not see them as people who are suffering so that, oh, no, they can just sit down there. It's bath time, and then we just take charge because we feel that we know what's best for them. We need to step back and let them have some control over their lives.
Okay,
so
somebody else
suffering.
said, what games or activities can be, I've just lost it, just bear with me. What games or activities can they play to keep them active?
Yeah, from the knowledge of the person that you know what their interests are, you know the kind of job they've done, and you know how you can stimulate. When we talk about stimulate, as the dementia progresses, some people are more physically active. You could take them for walks. You could continue to engage in different aspects that they enjoy, visiting friends, going out, going to the parks. But those who have challenging mobility, then it's slightly different because they might not be able to take long walks. So in that way, you have to look at things you can do with them in the house. Activities that they will continue to enjoy, game boards, quizzes, reading to them, reading with them, watching favorite cartoons that that they don't have to look at a long plot, that they can laugh and have joy. Massaging. Sometimes ladies who like to have their nails done and feet done. This is activity. You're engaging with that person. The sense of touch that we take for granted. People with dementia miss this. Hugging them, touching, giving them a bath, having their hair done. These are activities. We know of people who will still continue to go to the same hairdressers, even with advanced dementia, because they know that place. They know the hairdresser knows them, and they're comfortable, whereas nobody else will touch their hair, not even at home.
So there's another question.
The way we want it.
Yeah. Are people with dementia necessarily violent and abusive towards their carers?
Okay, that's nice to hear. Violence is a behavior. Why is it a behavior? It's a reaction. And why is it a reaction? It's how we engage. People with anger issues will not change because they have dementia, but we know that there's a dementia, am I going to stand akimbo in front of them and shout at them to do something? Will I get the right answer? Will I get the right response? Isn't it the way I will engage with them, talk to them gently, hold their hands and say, oh, Daddy, this is where we're going to go now. Will Daddy shout back at me when I'm talking softly and I'm smiling? Then, we tend to be authoritative sometimes when we feel that people don't have a mind of their own or they're losing their memory. We think that they do not remember what we've said or done to them. Yes, they might not remember, but the emotions of how you made them feel stays with them. Dementia is like an onion. I wish I have an onion. You peel an onion. Those are the short-term memories. So they might not remember what they've had for breakfast, or a friend that came to visit, or a grandchild that came to visit. But in the onions, other layers get peeled off gradually. So they might remember things that happened when they are working, and they can discuss with you on that. When they were in school, they might not remember the name of the teacher, but they can tell you their favorite subject. So there's always ways you can use at communicating and engaging as the memory starts to fade. But it's the short-term memory that you experience most.
Somebody said, is there any special dietary requirements for dementia?
Why should we have a dietary requirements for people? Why should they have a separate dietary? I don't know. You don't give me a diet that I don't want because you think it's right for me. People will continue to, yes, diet might change because they lose appetite, or the sense of taste starts changing and they want stronger flavors. Some might want more peppery meal. Some might want more spicy meal. Some might want more sweet foods. They won't eat the main meal, but they'll finish all their dessert and their pudding. And then you then have more fruit. So people have ways of building up their nutrition, to encourage well-being and a balanced diet. But I don't think, people with dementia tend to lose appetite anyway. So you don't want to restrict their diet for them to start losing weight.
Someone else says, would it be fair to say familiarity with the sufferer would make caring easier? I guess.
They are not suffering, please. They have dementia. They have a disease of the brain. They are not suffering because of that. It does that. That's how it affects them. That's the difficulties that we see, that we find challenging. Familiarity, you still have to know that you cannot be over familiar. You cannot be over familiar with someone that you know, that is a family member, because you know what they like and what they don't like. If a person has always been addressed in a particular nickname by those who are familiar, that nickname will always work, because they know, Omo, I'm here. That's my pally. You see, the man is relaxed, they chat, they talk, because Betty, because those are the, she's already smiling. You want to get her to change because she's had an accident, but by even starting the conversation with Betty is like, yeah, that's my schoolmate, she's happy. Even though she might not recognize you, she knows you're a familiar, a friendly voice, that you're not there for against her, you are there with her.
Okay.
Okay.
Ronke says, are there any special dietary requirements for much later in life to improve the situation?
No, still the same. People eat what they want to eat. You find someone who just loves to eat toast, and the carers are wondering, why does, she won't eat cereal. We're like, but what does it bother? They're eating nutrition, they're putting, just change the spread, maybe marmalade, maybe peanut butter, maybe jam, maybe make some eggs. Why should it bother you if this person wants to eat toast every morning? So it's us that we are challenged, not them.
Okay.
Okay.
I think we've answered a few questions. Can we do a selfie, if you don't mind, if you want your face to show on the camera, so that we can put an article about this on LinkedIn? It's all voluntary if you want to show in the selfie. And somebody said some schools of thought believe diet can be. Is it curable? No, it's not curable. We already talked about that. Okay, so I've done the selfie.
Food, about food, what food does to my audience is that it improves quality of life and well-being. It ensures that when they eat good balanced diet with fruits, vegetables, fiber, dietary diets, that you get them able to, move their bowels and feel healthy, and they're not constipated. Food works in any form of disease that we all have. It doesn't have to be any special for people with dementia. And don't forget the COVID-19 pandemic that we are in right now. You can imagine how it affects carers and those who are living with dementia. These are people that need help to negotiate the community, to be safe. And now they don't even know if they're going to have the disease if they go out of their community or out of their houses. Then they are more restricted, they are more isolated, they are more lonely, because everyone's now staying away, and family worry that will they be able to recognize them when they now have to visit at a distance, with a memory problem, with a visual problem. So people with dementia are part of the shielding group, where we must continue to remember and support, and for family members to look at different ways to keep them active as well during this period. Thank you all. Thank you very much.
One more question. Any story of reversibility? That's a good feedback from this session, Remy. We just had I just ran a poll for the session.
Story of
I was just talking about the poll for a moment there. I just ran a poll about the session, and it has come back very satisfied with the session, 85%, and 15% quite satisfied. So thank you very much for the effort you have put in today. And we have one more question here. Any story of reversibility in your experience?
Okay, what I can say is when people with dementia are on any of the anti-dementia drugs and it's giving positive effects, they are responsive towards that. Maybe not so much about the memory, but about their behavior and their daily activities. They're more relaxed, they're less agitated, they're more orientated with what's going on in their daily lives. And for some reasons, the family are not able to afford the medication and they've had to stop it because of financial constraints. You find that the dementia seems to progress more quickly because the medication then they can see that it was helping. And then when they then quickly try and continue the medication, it does slow down the progression. But in terms of it being reversed, it is not reversible. It will continue to progress, but at different rates, depending on the type of dementia, depending on the support, the family and activity and well-being of the person with dementia. If someone with dementia is ill, because the brain is already compromised, the illness can just make them feel so low, and not even able to engage, not to tell you if they have temperature, so you have to do the overall caring and well-being to keep them well enough to be able to improve on the physical health.
And just one last one, and then we can let everybody go. Some schools of thought believe diet can be an alternative to orthodox medicine. This is coming from Titi Fabanwu.
What I will say about diet and anything complementary, like complementary medicines or herbal remedies, is that if someone is on prescribed medication, you must always discuss that with the doctors, because if you went to start trying other complementary therapies or remedies with a prescribed medication, you might compromise the effectiveness of what they're on. And you don't want to do that. You don't want to compromise someone already with a compromised capability in the brain. So you don't want that happening, because they'll be more confused and you are thinking you're introducing something positive in their lives. So you need to have these early conversations with the doctor, because not all remedies or therapies agrees with people. Everyone is a person in their own rights, and what agrees with them is on an individual basis.
Okay. So I guess we've come to the end of the session, although we're going to still stay on.
Supplements is the same thing. They need to talk to the GP. You do not introduce any supplements without talking to the GP.
Okay.
Or your doctor, because if someone's got deficiency and you are using the wrong vitamins that it doesn't need, then you're just, it's not of any benefit. You need to have a blood test to see how you can improve that well-being. It's all about well-being. But, with dementia, we need to understand that we need to know there's a change going on in the brain, and we don't want to make things get worse for this person by introducing something that is not acceptable to the medical teams.
Okay, thank you very much, Remy. And for those of you who want to join Ninja Professional, like I said before, we are on Facebook and we are on LinkedIn. And if you need more information from Remy Okay, here's her email, please. I'm just going to leave that there for a second. If you want to note that down, if you need more information, if you think you know anyone who would need some form of consultation with her, by all means, please contact her. So I'm going to stop